So how do I program my Alaris pump? Currently, there are a lot of different options within the Alaris pump. There's weight-based, non-weight-based, then there's a VTE, there's an ACS protocol for patients who weigh less than about 83.4 kilograms, patients who weigh more than that. But we're going to be reprogramming the Alaris pumps now. So under heparin, you will have the following indications: venous thromboembolism, acute coronary syndrome, atrial fibrillation. We will have a low-dose vascular protocol. We are also going to have a high-dose vascular protocol. And then we'll have a fixed dosing protocol for patients, for example, who get catheter-directed lytics and are on a standard dose of heparin of, say, 500 units an hour. That doesn't actually even need to be monitored. So the first step is to choose the correct indication. And notice that it is found right on the order. As we saw before in the previous slide, the indication in this patient was acute coronary syndrome. Step 2 is to verify the correct concentration of the heparin infusion, just as we do currently. You notice in this case, it is heparin 25,000 units in 250 milliliters. And is this correct? Now notice that the dosing units for the infusion are now in units per hour and not in units per kilogram per hour. And the units for the bolus are in units, not in units per kilogram. Also notice from this that the weight is not entered into the Alaris pump as you're used to doing. However, as I said before, because the calculator is going to use the weight to calculate each of the doses we're going to use, it's very, very important when you get the heparin order to look at the weight that the protocol has pulled into the order set and ask yourself, is this the rough weight of my patient? In other words, if you look at the patient and he looks like he weighs 70 kilograms, but the heparin order says 140 kilograms, perhaps there was a mix-up in the units that were used. So it doesn't have to be exact, but you should verify that it is in the same ballpark as the patient you're looking at. Step number 3 is for 2 RNs to verify and confirm the correct concentration, just as we do currently. This is not any change. Next, you see that once you do that, it shows you the amount of drug, 25,000 units in 250 milliliters. And notice here that although the patient's weight is not utilized in the pump, it is used, as we saw in the medication order, to calculate the doses. Remember, it calculated the bolus dose, the initial infusion, and even the dose adjustments. But here in the Alaris pump, the weight is not going to be used. Notice that the dosing is in units per hour for the maintenance infusion. Once that is accepted, in step 4, we will enter the initial infusion. And in this screen, very similar to currently, we enter the volume to be infused. And in this case, the volume of the bag, 250 milliliters. And then what is the dose of the continuous infusion? Again, get it from the medication order and notice the doses in units per hour. So in this box I have here below, we are not using the weight in the pump any longer, so you don't need to worry about 12 units per kilogram per hour. You need to tell the Alaris pump the initial dose in this patient is 1,000 units per hour. And so when those pieces of data are entered into the Alaris pump, you can see that the volume to be infused and the initial infusion rate have been entered, and the Alaris pump has calculated the infusion rate based on the dose you want to give, i.e. 1,000 units per hour, which you can see corresponds to the green box in the order to the right, and the concentration, or 25,000 units, in a volume to be infused of 250 milliliters. And you can see that based on that it estimated and accurately calculated the initial rate of infusion as 10 mils per hour, or 1,000 units per hour. Step 6. You may ask yourself, was a bolus ordered with this order? If it was, then you would activate the bolus key at the bottom. And you notice that the initial bolus is right in the order. It tells you how many units the bolus is supposed to be. So on the next screen, you will take that bolus of 4,000 units that's in your order, and you will enter it in. And then step 8 is to choose rapid bolus so that the pump will administer it. And when you do that, You will see that it says the bolus dose is 4,000 units, and it will be given as a rapid bolus over 2 minutes. The total dose of the bolus is 4,000 units, and the bolus volume to be infused is 40 mils. Once you do that and verify that, then you press start, and it will give the 4,000 unit bolus. Then it will transition to the 1,000 unit per hour maintenance dose. Be sure to document appropriately in BCMA regarding this initial dose. Now, what about dose adjustments? We know that heparin protocols in virtually all hospitals are nurse-driven, and accurately so, as nurses do a wonderful job of monitoring heparin drips and adjusting doses based on protocols. So in this patient, let's say that 6 hours after starting the heparin drip, you enter the appropriate lab order under the ordering provider's name. In this case, we are using the UFH anti-10A, but it might be the APTT as well. Once you enter that and send it to the lab, or the phlebotomist comes and draws it, or if they have a central line, you draw it. Let's say in this case, the results are reported by the lab as follows. The UFH anti-10A is 0.21. Now what? Well, refer back to your heparin medication order. Again, it's all in one place. In this case, you can see that if the UFH anti-10A is between 0.1 and 0.29, ours is 0.21, that you would give a heparin bolus of 3,770 units, and then you would increase the maintenance rate by 250 units per hour. So we would go back to our Alaris pump and do the following. We would program a rapid bolus of 3,770 units, and we would increase our infusion rate to 1,250 units per hour, i.e. 1,000 units per hour that we have currently, plus the 250 unit per hour increase per the order above. And both of these should be verified by 2 nurses and documented appropriately in BCMA. So what are the key takeaways? First of all, it's very important to verify the patient's weight is correct in the heparin order before starting the heparin. As I said, when you get the order and it says the patient weighs in the protocol 70 kilograms, you should be looking at your patient saying, does he look or she look like they weigh about 70 kilograms? Doesn't have to be exact, but in the right ballpark, because as we said, the calculator will calculate the dosage you're going to enter in the pump based on that patient's weight that has been pulled into the protocol. So accuracy is paramount. If a pound's weight is entered incorrectly as kilograms, then it could result in higher doses than needed. And conversely, if a kilogram weight is entered incorrectly as pounds, it could result in lower doses than needed. Second, follow the prompts in the Alaris pump to enter the appropriate doses. Notice that bolus doses will now be entered in units, not units per kilogram. And continuous infusion doses will be entered in units per hour, not units per kilogram per hour. This is a change from our current process, but it is designed to decrease some of the confusion that exists between weight-based versus non-weight-based, especially in patients with acute coronary syndromes who may weigh more and then have to have the pump manually adjusted. Third, understand that some protocols will use the UFH anti-10A monitoring and some will use APTT monitoring. The orders instruct you which one you will be ordering and which one you'll be using. And last, double check your math when you have to increase or decrease the infusion rate. If you have to add 250 units per hour, as we did in this case, double check that math. If you have to subtract or lower the infusion rate, double check that. Also remember, it requires a double check by a colleague. However, you will now notice that the protocols have been designed to round to the closest 10 units, which makes it a lot easier and the math a lot simpler. So no more of those 528 units per hour doses that seem somewhat impractical and even unuseful. And last but not least, let us know of ways we can improve the process. Your input is important. I hope these protocols will be easier to use, a lot more straightforward, and will result in a lot safer use of heparin for our patients. Thank you for your time. The nursing educators are also aware of these protocols and can answer your questions, and I am certainly happy to answer any questions that you have. Just catch me when I'm in the hall. Thank you very much. Appreciate it.